Welcome everyone to this month's discussion of an interesting article published in the current issue of Neurogastroenterology and Motility Journal. My name is Dr. Purna Kashyap. I'm a gastroenterologist at Mayo Clinic in Rochester, Minnesota. It is my great pleasure to welcome Dr. Craig Friesen. Dr. Friesen is a professor of pediatrics at the University of Missouri Kansas City School of Medicine and the director of the Division of Gastroenterology, Hepatology, and Nutrition at Children's Mercy Hospital, Kansas City. He's also the co-director of the Interdisciplinary Abdominal Pain Program. He's been practicing as a pediatric gastroenterologist for over 30 years, specializing in functional abdominal pain disorders. His research primarily focuses on the role of inflammation within the biopsychosocial model of abdominal pain, as well as other brain-gut disorders. He has published over 100 peer-reviewed articles, and today he joins us to discuss his recent paper, Mucosal eosinophils, mast cells, and intraepithelial lymphocytes in youth with rumination syndrome. This was published in the current issue of Neurogastroenterology and Motility. Welcome, Dr. Friesen. Thank you for joining us for this chat today.
Yeah, thank you for inviting me.
I just wanted to start with some background on the paper. Can you give us an overview of the importance of role of inflammation in rumination syndrome and really the context which led you to do this study, because it's not something which is widely known or accepted?
Yeah, so I've had a long-term interest, as say, in inflammation, and particularly eosinophils and mast cells within, disorders of brain-gut, functional GI disorders. And, with rumination syndrome being one of those, it was intriguing to us, and especially with some of the overlap with functional dyspepsia. Like most or many people, when we start looking at functional GI disorders, we view them through a biopsychosocial model. And to date, really, the psychological and social factors have dominated people's approach to rumination syndrome. As an example, diaphragmatic breathing is the mainstay of treatment, effective, but for many patients, there's only a partial response. And at least in kids, the recurrence rate is pretty high. And so I do think there's a need to look, are there some biologic factors too? And given the role of eosinophils and mast cells in functional dyspepsia, they became of interest to us as maybe an alternative target. And I think particularly with mast cells being implicated in visceral hypersensitivity. But what got us to this very specific one was we're intrigued by a study done in adults by Dr. Howland and colleagues, where they demonstrated increased duodenal eosinophils and intraepithelial lymphocytes in adults with rumination. But with their patients, they weren't able to assess whether that was purely from rumination or whether these were patients with concurrent functional dyspepsia as the diagnosis most associated with that inflammation. So it got us thinking, okay, can we reproduce this study in kids, and how do we extend it? And so that led up to us developing this protocol.
Great, that's a great context. And I often wondered how we can get kids to actually do diaphragmatic breathing. It can't be easy to implement this in kids. Can you briefly describe the methods that you used in these studies, or the design for the study?
Yeah, what we did is used existing patient samples. So we queried our electronic medical record for patients who had been seen in the GI clinic and given a diagnosis of rumination syndrome. We then reviewed each of these charts to assure that there was documentation of those symptoms fulfilling Rome 4 criteria. We then looked to see how many had endoscopy. So we identified 50 patients, 46 had confirmed rumination, and 28 of these had previous endoscopies. And so we took their biopsies, their standard H&Es were used to assess antral and duodenal eosinophil densities and the intraepithelial lymphocytes per 100 epithelial cells. We then did immunohistochemical staining with using antitryptase to identify the mast cells. And we did this in both the antrum and the duodenum. All counts were performed by an independent person blinded to the group. And we compared them to a group of 10 controls. Controls are always a challenge, I will tell you, in pediatric studies. But what we did was we queried a pathology database for patients who had constipation as the indication who happened to have an upper endoscopy. We then went through their charts to assure that they had no other GI symptoms of any sort other than the constipation that was there. So why they got scope, we do not know, but they became our control group. and there were 10 of those patients that we could identify. So we then also looked through their records to see if they had a history of abdominal pain, this is for the rumination patients, or presence of early satiety, which were 2 questions asked in every patient. Anyway, we also then looked to make sure that there wasn't a selection bias for those patients who got scope versus those who don't, and essentially the symptom profiles were the same. So the symptoms we were looking at were not did not look like they changed whether or not they got biopsied. Anyway, then at that point in time, went in and did counts. There are so many ways that people have gone about counting eosinophils and mast cells. If there's any consensus, it appears that antitryptase is used more commonly, but certainly immunostains. But past that, how people select fields is really variable. I will tell you, we just recently reviewed 70 papers. Probably half of those, they didn't tell you how they selected the fields, and most of them that were done in adults were just random fields. How we selected them was we looked through the entirety of the specimen, selected those subjective areas with greatest density, and then counted 5 consecutive high power fields to get the mean and the peak counts. The reason we look for maximum is we think it standardizes better given the patchiness of it. But I do think that's one of those points that'd be nice to stabilize over time. But basically, we went through and then counted cells and compared them, rumination patients controls, and then patients with and without pain, with and without early satiety, and with and without constipation within that rumination group.
Great. It's nice to know that you went that extra step to try to quantify these. What were your principal conclusions from the study?
Well, what we found in comparing the rumination patients to the controls, consistent with what had been previously reported, we did find increased mean duodenal eosinophil counts and increased duodenal intraepithelial lymphocytes. What was new was we also found increased mean and peak mast cells in the antrum of these patients. When we looked at comparison, those patients with pain, so there were 16 patients with pain, 12 without, no difference in counts, whether there was pain or not pain. Same was true for constipation. When we looked at patients with early satiety, turns out there were only 4 patients with early satiety. So the group comparisons may not be terribly helpful, but they were actually increased in those patients with early satiety. What we elected to do at that point in time was to eliminate those 4 patients with early satiety and say, okay, in patients without early satiety, is there any difference? And what we found is that this rumination finding of these cells was really independent of or wasn't necessary for early satiety to be there. So those patients without early satiety compared to controls had increased eosinophils, mast cells, and lymphocytes. But the duodenal eosinophils were no longer statistically significant. P-value there was 0.07. So essentially, the main findings of this are, not only can eosinophils and intraepithelial lymphocytes be increased in the duodenum, but mast cells are increased in the antrum, and it really looks like this is independent of the presence of pain, or early satiety, ultimately, or constipation.
Great. In thinking of, you just mentioned that one of the drivers for the study was the lack of effective therapies because some patients just show partial response to diaphragmatic breathing. So how do you envision these findings affecting clinical practice? And do you think these findings are sufficient, or we need more controlled prospective studies to look at this further?
Yeah, absolutely. These should be viewed as preliminary. I mean, they're not huge groups, either in ours or Dr. Helen's study, which were remarkably very similar in our numbers. So I do think even the findings should be confirmed in a larger cohort, although I think the congruence between the 2 studies does increase the likelihood that it will withstand larger cohort. But clearly, there's a big step from finding an association with this kind of inflammation and deciding whether or not it represents a therapeutic target. And I think prospective studies, and you know, rumination is not going to be a homogeneous condition. And I think we know from all of the motility data that there are distinct patient groups, and there's going to be very different in how they're proportioned from adults to kids related to whether reflux is an initiating event or not, so primary versus secondary reflux, whether that's the lower esophageal sphincter relaxes before the R wave, whether it relaxes after. So there's going to be, I think, some mechanical subgroups, but even overall, if these cells are increased, the question still becomes, are they active? Are they targets? And, you know, with all kinds of inflammation, but particularly mast cells and eosinophils, when we go count numbers, it doesn't give us a full biologic picture. So they're active because they release mediators that really do the downstream work relating to symptoms. And so, you know, without knowing activation states, it's hard to say that they're clinically important. But the other question of whether they're targets absolutely needs prospective studies. But I think studies, you know, designed to look at decreasing density will be helpful. But more particularly, I think, you know, the effects of mediators being blocked by specific drugs is a pathway for studying this. But you know, I do think it's been shown, they've been shown to be viable targets in both functional dyspepsia and irritable bowel. And I think this means they probably are viable targets, but I would also say they don't replace teaching diaphragmatic breathing, teaching relaxation training. It's, you know, is this a biologic factor that when targeted can augment the response to treatments that already exist?
Great, this is really fascinating, and it's exciting to see that it's going to spur a new direction of work in this space. Any parting thoughts or things which we didn't address from the paper?
No, I don't think so. You know, the only other message that I guess I would want to emphasize is that, you know, those what appear to be straightforward rumination, I think patients to, you know, most GI docs of here's somebody who's ruminating and has no other symptoms, that should not say to us, okay, this is not a group we're studying because inflammation still may have a role in them, because you could be asymptomatic otherwise, and we were still finding these increased cells. But I think this will have to be multi-center studies to get enough patients, but I do think it's an avenue worth pursuing.
Great. With that, I'd like to thank you, Dr. Friesen, for your excellent paper and also for assisting in the podcast this month. And I'd like to thank our listeners for tuning in. I look forward to welcoming you again next month for another exciting article.
All right, thank you.
Thank you.